Thank you.
Hi, good morning. I want to start to say thanks to Cleveland Clinic Foundation, Dr. Raul and Fernando for give us the opportunity for sharing the knowledge about the colorectal surgery in these kind of meetings. I have no disclosure. The rapid evolution of technology has reshaped the surgical practice toward a paradigm of precision, involving the human-machine collaborations and the advance in intraoperative imaging. The common thread in technologic evolution, the augmented hand, that is the improvement of surgical tools like is the robotic surgery, and the augmented eyes that developed the concept of image-guided surgery. And why? One of the targets of this evolution is to avoid, or trying to avoid, the complication in our surgical procedures. One of the main problems with the ureteral injuries is that they go unnoticed. The majority of the cases of this kind of injuries are diagnosed in the postoperative period, leading a complication such as abdominal sepsis, urinary fistulas, the ipsilateral kidneys, and the cost of this kind of complication is very high. And the implication of the legal part of our profession have compromised when you have this kind of injuries. Years have passed, and colorectal surgery is quite well established and standardized. However, ureteral injuries remain a risk, especially when you make surgeries in advanced rectal cancer and endometriosis, inflammatory bowel disease, and diverticulitis. With these techniques, the need to place a catheter is obvious and allows precise localization of the ureter throughout the surgery. Systematic reviews of studies evaluate the utility and effectiveness in the intraoperative ureteral identification. They compare the light catheter or the fluorescence with ICG or methane blue. Of 158 studies that they evaluate, 12 met the inclusion criteria with a total of 822 patients. This systematic study demonstrates the benefit for performing the real-time ureteral identification and management of the intraoperative injuries. And this author believe in the future the prospective studies should focus in the ICG for this kind of identification during the surgeries. The next slides. Okay. With the patient in the supine position, lithotomy position, video endoscopy is performed with ureteral catheterization with 5 French catheter under fluoroscopic control. The tip of this catheter is placed in the level of the pelvic, of the renal pelvic, and 25 milligrams of ICG is dissolved in 10 millimeters of sterile water. 1 millimeter was injected in this catheter. The catheter is clamped during the surgery, and the procedure is allowed with the immediate visualization of the ureter. Can you put the next slide? In the identification of the ureter was 100% without lesions. The next slide. And I think that the speaker before me talked about this systematic review of Dr. Wexner, and they try to describe the currently available evidence regarding the efficacy and safety of the ureteral injury during the colorectal surgery. Can you, next slide? And the outcomes is to review the efficacy of the ICG guided in the intraoperative identification ureters. The efficacy, the next slide. And they make a review of 7 studies. All the studies was retrospective studies. Next slide. And they have one injury of the ureter and 3 complications with prostatic bleeding, transitory hematuria, and ureteral stenosis. The next slide. In conclusion, they think that is safe and effective techniques. However, these techniques still bears the potential disadvantage of the ureteral catheterization. They think that the research is focusing on future dyes to try to avoid this catheterization, and we need prospective randomized controlled trial for better results. Curative efforts are focused in the develop of this kind of diets. I think that the speaker before the next slide talk about these dyes. I think that it's a dream of all our colorectal surgeons that we try to don't use the catheterization of the ureter with injection. With this kind of dyes, I think in the near future we can use it. The next slide. I think that is a good option, but we don't have FDA approval and any other approval that we need to use in humans. The next. I think that we are in the right tools to prevent this kind of lesion. When you have a patient with a colorectal surgery, an anastomotic leak, ureteral injuries, it's a complication that all the surgeons try to avoid. La siguiente. This is, I will talk just show to you some videos. The next slide. You have to, it's our platform, the next slide. You have to make sure that the dye inject in the ureter in a way that will allow to spread evenly throughout the tissue. Next. Can you start the video, please? Okay. And we use ureter in all our cases, not just in emergency cases. In the elective surgeries with diverticular, this is a case with diverticular disease of the colon, and you have a lot of inflammation around the tissue. With this, with the identification of the ureter, we can make the dissection of the diverticular plastron without problems. Okay, we feel safely during all the procedure. In our platform, we have four kind of image in our monitor: the black and white, the normal way, and the green one. When we are making the surgery, the black and white have more resolution than the green. But the advantage of the green is that you can do the surgery in real time. Okay, but if you have are you confused or of the anatomical part of the ureter? I recommend to you the black and white, but the green one you can continue with the surgery without problems. The next video is very important when you are with residents, medical students, like the cholecystectomy. You can teach about the normal anatomy of the ureter and the pelvis. And when you have an inflammation, like this kind of diverticulitis with perforation that include the uterus, the ovarian tubes, and you can found the ureteral anatomical I can see, okay. You can identify the ureter without problems, okay? And it's very important when you are teaching to our resident or of our student that you can prevent the lesion. Can you put the video? Okay. When you have conversion, okay, in some cases we have to make conversion. you can use the same platform for identify the ureter. In this kind, the ureter is in the medial pelvis for the inflammation, and this kind of ureter you can make the injury during the surgery. The next slide. I think that fluorescence-guided surgery with ICG safely and effective techniques with ureter visualization with very low cost, and we recommend to use it. We need more prospective randomized controlled trial for make sure that we are doing the right way. But I want to say thanks again, Fernando and Dr. Rosenthal, for making possible that kind of meetings. Thank you very much.